So thank you everybody for joining. This is a follow-up on our latest webinar, the bacteria-mediated immunotherapy webinar. We had a lot of questions and we wanted to make sure we're answering to all the questions. So during this session, we are going to go through the remaining questions that we had during the webinar, and we will have Dr. Brenner and Dr. Kirby answering to all your questions. So we are going to start with the first questions around side effects and immune response. So we had several questions from Tani Pendleton, from Amy Williams, and Claudia Schmitz. The first one is any side effect with the use of bacterial therapy? Many side effects in the mouse study after injection. So these are questions about side effects. And will the patient, do you think they will need antibiotic treatment to counter that bacteria? Or will there be a systematic immunologic response as well? Is the body going to respond badly to this injection? So I let you, Dr. Brenner, or Dr. Kirby, to answer to these questions.
Sure, I'll take the first stab at this, and I'm sure Neil can fill in whatever details I leave out. So regarding the side effects of bacterial therapy, our intent in patients is to inject the bacteria directly into tumors. The bacteria we're using are not bacteria that are typically an infectious problem in humans. They're actually a mouse infectious agent. So I want to put that out as background. The exact bacteria we're using have been in several clinical trials, both by intravenous injection and injection, like a derivative of them injected into tumors. In both cases, they've been well tolerated. With the IV injection, there are doses at which people have experienced some sickness-like effects. With the direct tumoral injection, they were well tolerated intravenously by IV, but even better tolerated, it seems, with direct injection, which is what we're planning to know. At the end of the day, we can't really answer the question, and that's why we're doing the initial clinical trials, which I think this was a future question, but I'll mention it, would be in adults, in tumors in the arms or legs, somewhere far away from the spine and brain, where if we found some sort of reaction or problem, it would be in a patient and in a location where it wouldn't tend to be a big problem, like in the brain. And I would also answer a kind of future question, which is one of the good points of these bacteria, which don't normally infect humans, as I said, is that they're very sensitive to antibiotics. So if someone does have a side effect, the response is treat with antibiotics. And that very readily kills the bacteria. Regarding side effects in mice, with the doses we use that we see response in the tumor. So the tumors in certain models completely going away, or in other models, growth being controlled, we don't see any side effects that we notice. The animals don't look sick, they're not weak, they're not stumbling around, their behaviors are all normal. It is true that because these are bugs that can and do infect mice naturally, we could inject enough to kill a mouse, but that's way above the doses we need in the tumors to treat the tumors. Anything that I missed, Neil, on that?
No, it's good.
Should I go right on to the question below?
Yeah. Yes. So you're still on the the how often will tumor be injected?
So again, a lot of these questions, the answer is we really don't know. And that's why we do stratified testing in humans as required by the FDA. Our plan would be to actually start with 2 injections over about a month directly into the tumors. As I mentioned, distal tumors not associated with major neurologic structures like the brachial plexus. I know that was a question down the road, the spinal cord or the brain, and that's for safety reasons. We don't think that patients would need antibiotics, but part of our clinical protocol might be, it's not completed, that everyone at the end gets antibiotics just as an added safety measure. Certainly in patients, if a patient had signs of a local or systemic infection that was problematic, they would immediately be treated with antibiotics if it was found to be necessary. And then there's a second part of that question, the impact of the bacterial injection on untreated tumor makes me wonder about systemic immunological response. How does that impact safety? Well, honestly, our hope is there is a systemic anti-tumor immunologic response as one of the mechanisms of how these bugs can help control, hopefully, multiple tumors at the same time. Again, we won't know until we try this in humans. As I think Neil and I made clear in our presentation, no one has ever tried bacterial therapy in a non-cancerous tumor. So to some degree, we're hoping we see better effects than has been seen in treating cancers with bacteria. And I think that's a little beyond the scope of today's discussion, but there's several reasons that we think this could be and will be the case. But again, you don't know till you try. I don't think that there's a major reason to think that the systemic immunological response would be autoimmunity, which means directed at antigens in the patient. That's how it could cause a problem. Our animal data and our hope is that the immune response is really just to the tumors themselves. Again, you certainly can't guarantee that, even if we feel it's very unlikely. And that's why, again, we do clinical testing in a stepwise fashion. Neil?
That's perfect. Thank you.
Thank you.
Thank you. Next question is around Avastin. As you know, many patients, NF2 patients, are right now taking Avastin or took it in the past. This is a drug, an inhibitor drug that sometimes can slow down the tumor and even shrink vestibular schwannoma in some cases. So that's why the people are asking the questions if will it be numerous injections such as Avastin in the hope that the immune system would kick in? And also another questions, will it be, does this only treat schwannoma, meningioma, or epineumonoma as well? And so if you could answer to these questions, Dr. Brenner or Dr. Philby.
Sure. I think I can get a start at this. So I think that a pharmacologic like Avastin and the way a bacterial treatment work is very different, though one of the ways the bacteria seem to control tumors is by inhibiting angiogenesis or vascular development. So that's a positive. We, again, I hate to say it, but we don't know. What we do believe is that multiple injections, if necessary, either in the same tumor or in multiple tumors, is very feasible. You know, there will be an immune response to the bacteria, but one of the advantages we believe of directly injecting in the tumor is that even when that occurs, the bacterial injection should still work because in the tumor, it's what you might call a privileged immunologic environment to some degree. So we can kind of overwhelm the host's desire to kill the bacteria, because they are pathogens, by having a high concentration within the tumor, even after multiple treatments. And of course, our hope is, as mentioned, that the immune system plays a role in tumor killing, and our animal data very, very strongly support that, which is one of the reasons we're so excited about moving this to clinical trials. Now, right now, we are really razor focused on schwannomas associated with NF2. And that's not because we don't care about the other tumors. It's not that we don't care about NF1 patients. It's that, and maybe Neil comment on this, because this is my understanding about therapeutic development, it's extremely important to really be focused on an initial goal. Now, anyone who's looked at our PNAS paper knows that we are also kind of looking ahead. We have shown efficacy in 2 meningioma models, as well as 2 malignant peripheral nerve sheath models. So we're not aware of the need outside of schwannoma, but really initially that is our focus. And the information that we can gather by testing this therapy in schwannomas would undoubtedly help us with an understanding of how we might utilize and modify the approach for other tumors. You may be aware that there's really very limited models for ependymomas, only one, and it's not fully developed. So there is a barrier to preclinical testing in ependymomas. It's obviously a very valid question. I think it's a harder one to answer because of that limitation. Neil?
Yeah, I just to emphasize the point Gary just made, I think that for a small company with a limited resource, be it financial or people, focus is so important. And, making sure we do the right study. That first study is going to open up a lot of doors, actually, if we get the results that we think we're going to get. And just to reiterate about multiple dosing, all of the data that Gary presented is with one single administration of bacteria, even in the rechallenge model. So that's a very powerful argument that, we expect a significant effect after a single injection rather than multiple injections, but we'll follow the data.
Thank you. And regarding the mice model for ependymoma, NF2 Biosolutions, thanks to your donation, we are funding the lab of Professor Calamarides, and he's working on developing a mouse that is developing NF2 type of ependymoma. So as Dr. Brenner is mentioning, there is no model currently available to test. So again, thanks to your donation and your involvement, we are creating tools that the labs are needing in order to develop therapies. More questions. So another question from John Matt. It's an early slide that you presented in the webinar demonstrate that you have 75% response. He's wondering what happens to the other 25%. And many of the slides also demonstrate stability early on, but then a slight increase over time. Could you explain about that?
Yeah, I think there's a couple points to be made. First is the fact that 75% of these human xenograft tumors, so a human NF2 schwannoma cell line implanted into mice that lack T cells so that they don't just kill those human cells. The fact that 75% essentially go away completely, that was astounding to us. Not something we ever expected. The fact that 25%, there's excellent growth control, but there's still some cells hanging around, that's still a huge signal in this mouse model. I would just say that a couple other things related. I really look to the mouse models to tell me, is there something interesting enough here to pursue clinical testing? I really don't think any animal model can ever give you all the answers that you're going to get once you test in a human being, because humans and mice are not the same. We do look for tox signals. So related to that question earlier, it's very important that in our animal models, we don't see side effects with these doses that have such good efficacy, such good effect. I will also mention that in both our animal models, the xenograft model with human cells and the mouse model with mouse schwannoma cells, these cells are dividing quite a bit more rapidly than the human schwannomas do. So the fact that we see such a obvious, really astounding effect in tumors that are growing faster than in humans, my hope is that that indicates the likelihood that it's going to work even better in human beings where these tumors are growing much, much less rapidly. We haven't done the experiment where we keep animals alive for 3 or 6 months with the tumors. Frankly, we don't think it would give us meaningful information that would justify the suffering caused to the animals, which is, we've certainly considered it, but that's the answer for why we haven't really looked over a longer time. What does the regrowth possibly mean over time in humans? I would just reflect back to what I just mentioned, that these animal tumors are developing much, much more rapidly than human benign neoplasms. So my hope is the bacteria really control growth even in a much more substantive way than we see in the mice. Next question, would you expect there to be any adverse effects if people have been taking drugs like Avastin and then proceed to bacteriotherapy? I don't think so. I don't think there's any reason to suspect there would be an interaction. If on Avastin, how long would you have to be off? I'm just listening to the people who have much deeper experience in clinical trials than I have. And I think the answer is usually something on the order of 3 months. We certainly wouldn't want immunocompromised patients or patients on immunomodulators in the initial trial. Down the road, that might be something that is investigated, whether that's a problem or not. Third question, if this worked successfully in peripheral tumors, would the hopes be to go to the brachial plexus tumors? As I think I alluded to, we're starting with these peripheral tumors that aren't associated with major neurologic structures to be cautious. And I think that's always appropriate. The last thing we'd ever want to do is make someone's problems worse. Obviously, our belief is this is going to make things better for patients, but as Neil indicated, you have to get into human beings and get the information and follow the data. As I also kind of alluded to, we would naturally want to plan to use the therapeutic for perispinal, brachial plexus, and intracranial tumors. I think a therapeutic that doesn't address those tumors in NF2, unfortunately, would have fairly limited value. And naturally, at some point, we hope to test in children. And we wouldn't start there for obvious reasons.
Thank you. Are you planning to include hearing function as an endpoint of the clinical trial? And also, again, that's you answered to it as well, but the need of frequency of injections to maintain the effect over time.
Yeah, so certainly for the initial trial, we wouldn't include hearing function, given that we're not treating intracranial or cranial nerve 8 tumors. Down the road, when we get there, hopefully, that would certainly be a reasonable element to look for both improvement in hearing, and also you would want to look obviously for a decrement in hearing as a potential tox signal. But that's not a study that we've directly planned yet, though we've certainly thought about it. And we've certainly talked to multiple neurosurgeons to kind of get their temperature on injecting intracranial tumors, not just once, but multiple times. And I'll mention that we've received very positive feedback from the folks who would actually be doing the injecting of these brain tumors, that they think it's absolutely feasible.
Thank you. In the best world where there is no toxicity issue, it works great, and the money is flowing in to develop the drugs. When do you think it will be available in hospitals?
Yeah, do you want me to take that one, Gary?
Yeah, I think that's a Neil question.
Yeah, so it's really a question of how long does it take to develop a drug? And a lot of that timing is depending upon the quality and nature of the safety and efficacy data. So in this blue sky scenario where everything's great, it's very efficacious and very safe, you know, there still would be the requirement to do a larger trial than the first study. Additional patients would need to be treated. That safety and efficacy would need to be established, documented, and validated in a second study. So to approval, you know, we're still looking at 2 to 3 years to get to an approved product. And in the absence of an approved product, of course, everything that would be done would be under the auspices of a clinical study, clinical trial, which would be done in specialist centers rather than in local hospitals.
Thank you. Can foreigners participate in a future trial?
Yeah, I can have a go at that one as well. So all the clinical study that's being planned right now will be done only in the US. And that's from the perspective of let's get this done as quickly as we can. It's quite difficult to do clinical studies outside the US, particularly with exporting drug to other countries. So this will only be in the US. There's no ban on foreign patient, non-US patients being treated in clinical studies in the US, but they have to be present for all the follow-up visits. So, you know, we're not excluding foreigners per se, but they have to be able to be present and attend all the follow-up visits that they would in the United States.
Thank you. Questions for Mary Young. She's wondering the timeline for children, since she has a young child, a 5-year-old child. And what do you think will be the timeline where it will be allowed for children to use that drug?
Well, of course, it would be, again, in the clinical trial setting, the first time that it would be used in pediatrics. And that's going to be very much driven by data as well. So I'm not going to give any dates for when it's going to be available in clinical study in the pediatric setting. But it will obviously come after we've established a safety and, you know, efficacy profile in adults first.
So all the phases will be done on adults, and there will be a drug for adults? No.
Sorry, we'll do the first study in adults, and then we'll take a look at the data and it'll tell us where we're going with the next study. Obviously, it would be great if we could get pediatric patients into clinical study as soon as possible. But I would see parallel efforts.
Okay. A question from Elena Roll. What kind of investors might be interested by investing in Mulberry?
Well, that's a big question. You know, the financial environment is a little strange right now. Looking for investors, and there's a different pool of investors that would have been interested in this kind of an investment 2 years ago as it is right now. I mean, we're talking to all kinds of different investors. We're talking to angel investors. We're talking to what we call strategic investors, which are companies, bigger companies that might have an interest in this particular disease area. We're also talking to venture capitalists. We're talking to wealthy individuals. We're talking to foundations. We're talking to lots of different potential kinds of investors. So where that money comes from in the end, we'll see. But we're talking to lots of different kinds of investors.
Thank you very much. I think we are done with the questions that were left over after our latest webinar. Thank you again, Neil and Gary, and see you again for an update in a few months from now.
Okay,
Great.
thanks, you.
Thanks.